Welcome to Sunday, the 15th of October, 2006, CFUN 1410 AM, experts on call. And do you ever feel sad? Do you ever get that sense inside where you don't get excited about the stuff that you should be getting excited about or that you have before? Depression is a really complex issue, but with some surprisingly simple solutions. And we're very happy to welcome one of our most popular experts here at CFUN 1410 AM. His resume includes heading up the Faculty of Child Psychology at the University of Ottawa, prior to lecturing in psychiatry at Harvard for 7 years before moving here to Vancouver. But most recently, he's become one of the leaders in the field of biofeedback and neurotherapy, which is the medical science of adjusting brain waves. We're very lucky to have him here in Vancouver, and answering your questions and your calls today is Dr. Paul Swingle, and this is It's All in Your Head. It's nice to see you again.
Good to see you.
I guess the key with depression is, and this is something that brings a lot of people to your clinic, and I know there's people listening right now that have suffered from depression. The key really at the outset is identifying what type of depression they're dealing with.
That's 99% of the issue. Depression is a very complex disorder. We have depression that's reactive. If somebody dies, for example, you have a grief process. The treatment of that is very different than depression that's genetically predisposed, for example, or something that's related to an injury, or postpartum depression, or depression in adolescence. The first thing that we do is we do a brain assessment to see what we're dealing with, what type of depression, that is, what neurological type of depression that we're dealing with, and where the areas of opportunity are in terms of normalizing brain function. Then we do some neurotherapy to correct those conditions. If any other therapies are useful, and we certainly can help that, we consult with nutritionists and so forth, so we cover those bases as well.
Depression, for those who really don't know how to identify it, I mean, if you have it and you've had it for a long time and your family's had it for a long time, how do you even know that you have it to go and get help is one of my questions. And by the way, we're going to answer a lot of your questions here today. If you have a question about how you feel, or if it's a seasonal type depression, or if something's happened traumatic in the past, we'd love to hear from you. Dr. Swingle helps a lot of people right here over the phone, and then you end up getting a lot of patients as well through this process. How do people know? I mentioned feeling sad, not getting excited about things that you usually get excited about. What are some other keys that you may actually be suffering from depression?
Yeah, that's a perfect question. A lot of individuals who have a long-term exposure to depression don't know what it feels like not to be depressed. They assume the world is glum. They look through it in dark glasses and so forth. And it's interesting, sometimes when we treat chronically depressed individual, we prepare them for the fact that they're going to get into a state in which they don't recognize the emotional state that they're in. A period of anxiety is not unusual there because they're so accustomed to being depressed. Now, depression can also express itself as just lack of interest. You're not interested in anything. That's more typical in young adolescents. It may not be frank sadness, and they may not look depressed. They may just be uninterested, laying around, can't find anything, bored. And we tend to attribute that to adolescence and, why don't you get out and do something, et cetera, et cetera. We have a look at the brain and see if there's any predisposition there and check out whether the child has been exposed to things that might be causing a depression, for example, being isolated from a social group and so forth.
Very popular and common, of course, at that age group. We're going to try to cover every aspect of depression that we possibly can. Dr. Swingle mentioned postpartum depression, family disorders, and then we're going to talk, of course, about medication as well. And I also want to tell you about a public lecture and workshop that's coming up before we get any further, because you're going to actually demonstrate how brain mapping and biofeedback works right in front of the people at the lecture.
That's correct. This is an unusual situation in which we have 3 hours to do a major demonstration of full brain mapping, in which we have what are called topos. We can see how the brain is actually functioning under various conditions. And then we can use those data to go into another program that will allow us to look right inside the brain. So we're looking at subcortical structures, and we can rotate the brain around so we can see what subcortical structure is associated with particular activity on the surface of the brain. Folks will be able to see what several forms of depression look like. There are some forms in which it's an imbalance in the way the frontal lobes are working, an inefficiency in the processing of information. And those are the sorts of things that are corrected with neurotherapy.
Neurotherapy is something that I'm sure when you talk about what you do to your friends or to colleagues and they say, well, what is neurotherapy? Why is it that so many people don't know about this being an organic and a safe and a natural and a scientifically proven way of dealing with issues?
It's interesting that it's not on the radar more efficiently. It's been around for the better part of 4 decades. Its initial use was in the treatment of epilepsy and seizure disorders. The equipment we use is all FDA registered and compliant. Even the databases we use are FDA registered, which is in stark contrast to many other kind of treatment procedures, even some medications. In any event, I'm doing my best to try to get it up on the radar. As you know, I've written a book called at least the working title is It's All in Your Head. See, I seem to be fixated on that.
It's a good theme. Is it possible, too, Dr. Swingle, that, we've seen these movies like One Flew Over the Cuckoo's Nest, yes, where people think that neurotherapy is like electroshock therapy, where it's something that's...
No. If you think about bodybuilding, exercise, if you have an area of your body that's weak and you want to strengthen it, you go to a gym and your trainer will say, now this series of exercises is going to strengthen this area of the body. It's going to make it more flexible. It's going to integrate it better with other physiological activities of the body. That makes perfect sense to people. If you apply that same understanding to the way the brain works, we want the brain to work efficiently. And when it's not working efficiently, we have all kinds of symptoms associated with that, everything from mood disorders like depression, anxiety, problems with sleep, fibromyalgia, attention deficit disorder, muscle problems, gait problems, and so forth. So we treat stroke, we treat closed head injury, we treat epilepsy, in addition to things like depression. The method is very simple. What we do is measure brain activity and set it up so that the person can control their own brain activity, just the way you control your own muscle activity. So when the brain is doing what we want it to do, you'll hear a tone or see something move on the screen, and it's telling you about a brain activity you couldn't possibly feel, but you make use of that information to learn how to regularize brain activity. If it's a child, we set it up so that they're playing a video game with their brain. They're making an aircraft fly, or they're making dolphins jump in the water, or Pac-Man move across the screen, so that it's entertaining and engaging to the child. Now, we have other techniques that we can use for, like an autistic child who can't pay attention, can't play a video game with their brain. These are referred to as the brain drivers, and my clinic was the one that in North America that developed the brain driving technology that we use for these very serious cases. And in that situation, we measure a particular aspect of brain functioning. Based on that measurement, at a rate of about once a second, we stimulate with light or sound. With adults, we use microamperage stimulation, EMF fields, to nudge the brain into more normative functional patterns. And then when the autistic child is able to pay attention, we switch over to the video game. So it's very efficient. And again, my clinic is one of the few in North America that will accept very severe autistic children. Depression, by comparison, is a cakewalk in terms of treating that relative to the other kinds of problems that we deal with.
It's nice to know that depression is considered a cakewalk, and mood disorders and depression sort of crops up a lot at this time of year. We're going to cover all sorts of different aspects of depression. We'd also like to take your phone calls. Let's welcome Audrey to the program. Audrey, thanks for waiting. You're on with Dr. Paul Swingle. It's All in Your Head on CFUN 1410 AM.
Thank you. I had a severe whiplash injury in '92 and was off work for over half a year and went back to work not because I was any better, but because I financially had to. And pain has just got worse and worse, deeper, harder to treat. And for the last 4 or 5 years, I've been on opiates, which are the best as far as pain relief, but I've had facet joint nerve blocks and Botox injections into the base of my skull and my back and injection therapy and acupuncture, intramuscular stimulation, everything that there is going I've had, and it either made it worse or did nothing. And now I'm at a point where pain is worse. It's spread down to encompass all of my spine and down my arms and hands, and I'm just wondering what neurotherapy. And of course, when you're in severe and chronic pain year after year, it does cause depression because your life is so changed. You know, when I have a period of a couple or 3 hours during a day where pain is controlled, I don't feel the least bit depressed. I want to do as much as I can. So I think it's to do with being in pain that causes you to feel so down.
Thank you for sharing that with us. This is a very, very good example of a very complex situation that gets set up. You have traumatic brain injury from the whiplash, and it affected the frontal cortex. And what's happening now is it has evolved into fibromyalgia, chronic fatigue. The fibromyalgia is the pain that you're experiencing. I assume that you feel kind of foggy in the head, yes. And then they give you opiates to try to deal with the pain, which makes the fog worse. They try to control the pain by deadening the nerves, which affects mobility. Then you become depressed, and they put you on antidepressants, which has their own set of side effects. Am I pretty close to what's happened to you?
Well, I've been tried on many antidepressants to raise the serotonin level, but it was either it did absolutely nothing for pain, or it stimulated my brain so much that I couldn't sleep.
Yes, and your sleep is bad anyway because of the pain.
It's non-restorative.
Yes. Well, the answer to your question is we treat a lot of conditions like this. The first is to determine just where the areas of inefficiency are. Usually when we have a fibromyalgia-related brain trauma, there was a pre-existing condition that made you predisposed to developing fibromyalgia and depression because of the whiplash. Now, it doesn't matter how you're hit. When your head is shaken, the frontal lobes are always affected because of the way the brain sits in the cranial vault. And the frontal lobes would be affected, and what we would expect to see in your case is excessive amount of slow-frequency brain activity up in the right prefrontal cortex, and that's correctable with neurotherapy. There are some other things that we recommend in addition to what we do, cranial stimulation, and probably something like enteric-coated omega-3 would probably be helpful here as well. But in any event, the answer to your question is we see a large number of clients with this kind of condition.
Now, from the moment of impact, I also had problems with blurred vision that have continued on. And what I called initially, until I found out there was trauma to the brain, I called it cloudy thinking because I have problems with anything to do with tracking.
Yes, that's called fibrofog. A lot of folks with fibromyalgia have that kind of thing.
Audrey, thank you so much for sharing your phone call. You've offered Audrey some real hope here. That's a tough situation she's in, and really appreciate the phone call and sharing that. How many treatments do you think it would take to get Audrey back feeling normal again?
Well, probably in the range of 20 to 30 would be my guess. Now, my crystal ball is foggy, of course, because I haven't seen Audrey's brain.
Right.
But the situation here is that we have a level of chronicity. She's had this condition for a while. She also has complications of being on opiates and being on medications, which has exacerbated the problem. It depletes some of the neurotransmitters and so forth. So we have a lot of that to catch up with. The good news is people usually notice a change within 2 to 3 sessions. It's not over then, don't misunderstand me, but people know they're on the right track because the brain is starting to regularize even within that short period of time.
So here we had an example of depression as the byproduct of a traumatic brain injury. Depression is our subject today. Want to get into medication in just a moment here. There you could see how Dr. Swingle could potentially help you, and I hope that Audrey feels even better knowing that there is a solution for her problem. And there's so many different types of depression. Some kids have depression. There's postpartum depression. There's the depression you get after stroke, a heart attack, breast cancer, traumatic brain injury. Maybe it's a family disorder. As far as medication is concerned, why is it that so many doctors unilaterally just say, well, you're depressed, take this many milligrams of this, as opposed to perhaps something like neurotherapy?
Well, we've kind of been conditioned to think that we can deal with our problems by popping a pill. It's a real problem we have in our culture. I'm the first one to believe that if somebody is in real crisis and ready to jump off the Broad Street Bridge, we don't want to fool around. We want to give them some medication, get them under the care of a really first-class psychopharmacologist. get him bridged from one place to another, and then we can start some sort of therapy to deal with the depression and get him off the meds. Most really competent psychopharmacologists have exactly that position. The problem is that relying on medication doesn't cure the problem, that it often exacerbates it. There's some very, very interesting data on what happens when individuals go on antidepressant medication. The actual number of depression episodes increases when a person goes on antidepressants. This was information that was published in the Archives of General Medicine in terms of the number of depressive episodes increases sharply when you go on antidepressants. Now, that's very interesting because what happens there is that you start to increase the amount of antidepressant. Sickness absence is more prolonged when a person is on antidepressants. Now, what that suggests is that the antidepressant is not being used in an appropriate fashion. For example, if an individual has experienced what we call reactive depression, somebody dies and you become depressed. Of course you become depressed. You should never, ever medicate that. The reason is you never deal with the grief. And we don't treat reactive depression. If somebody comes into our clinic and the depression is a reactive depression, say grief of a death, we can do some things to help them process that grief, any predispositions they have to depressed mood state, things of that nature, but that we do not sedate or suppress the grief process. If they go to a physician and the physician says, well, here, take a few of these, this will help you through it, very often what that does is prolong the process and create a problem, because then when they start to try to come off the medication, they're not feeling so hot. Well, hello. Now's the time when you're going to have to process something you should have processed a long time ago. So there are all sorts of issues associated with when you're going to use medication, for how long, under what circumstances. And we work very closely with psychopharmacologists, psychiatrists, physicians, and so forth in terms of dealing with some of these crisis situations. For folks that are experiencing depression, that is an episode that keeps coming on and coming on and coming on, and they're not medicated. They come in, we correct the anomalies in the brain, they go home, and that's it. They're going to get depressed like anybody else. Life is a window of emotions, and if you use medication, you're narrowing that window. You're sedating yourself, in other words, and you want to be very cautious of that.
When you talk about self-medication after something like a traumatic episode or grief, does that include marijuana and alcohol or other drugs?
Yes, self-medicating is a real problem. A lot of people feel that alcoholics, for example, universally have a depression issue. I'm not so sure I agree with that, but nonetheless, a lot of people self-medicate with alcohol. Prescription medications can be used in a self-medicating kind of way. People start to take codeine, for example, what they represent it as being for their headache, when it really is a mood modifier, is the reason they're using it. Marijuana, of course, even TV. You can distract yourself by simply becoming addicted to just sitting in front of the tube all day.
I want to ask you about SADS as well. And this is a common time of year where I'm sure you see a lot of patients who are coming in feeling blue and aren't really sure why, or there just doesn't seem to be a whole lot of hope as we go into hibernation mode, I guess. Can you maybe explain SADS, and is it an actual thing, or is it just one of these buzzwords that sort of came out because of people feeling not great or depressed?
No, SAD is a real condition. And it's associated with a change in the light, which affects the circadian rhythm in the body. And individuals who are prone to SAD have a neurological predisposition. We can treat that by treating the neurological predisposition to that condition. There are several issues with SAD. The first is to keep in mind that there's light at the end of the tunnel, which is very difficult to do if you're in a depressed mood state. Everything is sitting right in front of you. You lose time perspective. But just remember, once the daffodils bloom, you're going to be out of your depression. The second thing is there are some things that you can do in addition to neurotherapy. Now, neurotherapy would work with the predisposition to depressed mood states, but there's also light boxes that you can use. You can watch your sleep. Make sure that you don't spend a lot of time in bed. Get up when the sun rises. Take a warm bath early in the morning to increase body temperature, which is your circadian rhythm. There are a lot of things that you can do, even omega-3, but you want the enteric-coated omega-3. And there's been some recent research on omega-3 and suicide rates, for example, which, of course, is directly related to depression. So there's a lot of things that you can do. If we can normalize the brain so that you don't have the predisposition, you're less vulnerable to these troughs that you go through.
Now, you touched on something earlier that I thought was very fascinating about adolescents and how they just sort of seem to lay about sometimes. And I have to admit, there was times when I wouldn't mind just spending a whole day watching TV when I was 13, 14, and 15.
Really?
Oh, yeah. Hard to believe. I'd like to know, let's get into that a little bit more. I'm sure there's a lot of parents who wonder, is my child just unmotivated or are they depressed? We have Barbara on the line who wants to talk about her son. Barbara, thanks for waiting. You're on with Dr. Paul Swingle on CFUN 1410 AM.
Oh, thank you. My son has schizophrenia since he was about 17, 18, and he's 50 now, and he's just spent his whole life sitting around smoking, drinking coffee, and seems to have lost all ability to do anything. Any tasks or anything that he could do before, he seems to have forgotten how to do. Is there any hope? He's been on all different medications throughout his life.
Yes, we see a fair number of psychosis clients. As you probably know, there's a move to remove the label of schizophrenia because it's not really very helpful.
Yeah.
What folks with this disorder have is an array of dysfunctions, and there's no uniform array of dysfunctions. Folks differ in terms of the kinds of problems they have.
Yeah, everyone seems different.
Now, this is a good example of where we would not do the rapid intake that we do commonly with clients with simple problems like depression, simple problems like ADD. For something like schizophrenia or closed head injury, epilepsy, autism, and so forth, we do full brain maps. And in a full brain map, we put a cap on the head and we look at all 19 sites simultaneously. And we are able to get very precise measurements of brain site to brain site communication, which is what the problem is in schizophrenia. Mm-hmm. The brain's not talking to itself properly. So once we isolate what areas of the brain are not communicating properly, we can set it up so that when the brain is talking to itself properly, that's when the icons move on the screen. So it's a very sophisticated, very specific area of brain activity that we're working with. Depression, of course, it's hard to know what's depression in this context and what's really the schizophrenia. Mm-hmm. Anxiety is usually a feature associated with it, so the person becomes more and more lethargic to deal with the anxiety. You know, they're not going to get anxious if they sit in the corner and don't do anything.
Yes.
As soon as they get up and try something, then the anxiety hits and they withdraw again.
Yes.
Barbara, is your son on any medication that you know of at the moment?
Oh, yeah. He's on, he's not on heavy doses of anything, but he's on, I think it's risperidone and a mild antidepressant.
Do you think, Barbara, he'd be open to trying something? Is this something that he wants to, get beyond as well?
He never really talks much about anything. I mean, it's just sort of, I don't know. Can't concentrate on anything for very long or anything.
Well, that's really...
Well, he's habituated to his problem.
Yeah.
Really appreciate the call, Barbara. Here's Dr. Swingle's number. It's 604-608-0444, 604-608-0444. And you get more information as well on Dr. Swingle's website, Swingle and Associates. Now, with adolescents, and what age are we talking? Anywhere from 13 to 18 years old? Is it that they all of a sudden, is it hormonal? Is it the social anxieties that start to develop? Well, why is it that adolescents tend to get depressed?
Well, if you think back historically, adolescence was a period of adventure and going out and establishing oneself, making use of very high energy levels. In our culture, all of that's suppressed. The child has very limited opportunities to express these hormonally based urges that they have. Depression in an adolescent, particularly an adolescent male, is usually characterized by lethargy and obstinance. They've tacked a label on this. Oppositional defiance disorder, ODD. We love acronyms, don't we? And the ODD is often a problem associated with depression and emotional impulse control issues. And those are all associated with the frontal lobe. You can see it when you do a brain map. By the way, I think you've mentioned a few times, when folks come to see me, I don't ask them why they've come.
Right.
We do a brain assessment and tell them why they're there. So when an adolescent comes in and I say to the parent, it looks like your son is disinterested in things and has a real problem with oppositional behavior, their eyes light up and they just have no idea how I was able to come to that conclusion. But in any event, you can see it in the brain. So what we do there is treat the impulse control problem. And also, since we're all registered psychologists in the practice that are supervising the cases, we do behavior therapy with the child as well, so that we establish goals. What is it that the child wants to accomplish, and how can the child accomplish them? So that's the other component. It's one of the reasons why I'm so adamant that neurotherapy is not a standalone treatment. So all the hobbyists out there who are running neurotherapy practices and slap an electrode one size fits all, you're in real dangerous territory when you do that. You need to be treated by somebody who has a license to practice another discipline like medicine, psychology, social work, chiropractic, whatever.
What about girls? Is there a difference in girls that you see at the adolescent stage in their life?
You're less likely to see that protocol in females. You're more likely to see it in males. That is the loss of interest. There are several reasons for this. Females have better support networks. You know, they're more sociable. Their depression tends to take different kinds of expression, different methods of expression.
Let's welcome Moira to the program. Moira, thanks for being on with us. You're with Dr. Paul Swingle on CFUN 1410 AM.
Hi, I just had a question about panic attacks. I was wondering whether Dr. Swingle could talk about the causes and maybe treatments, and whether there's any link between panic attacks and depression.
Yes, we treat panic disorder. There are several different types of panic. There's what's considered classic panic disorder, and that's characterized by a marked change in the way your vascular system is responding to stress. There's a major dilation of a lot of the arteries so that body temperature goes up under stress, which is exactly opposite of what the normal reaction is. Your normal reaction is a decrease in peripheral blood flow, which means a decrease in external body temperature. That's the classic. So the way we correct that is we correct that with what we call peripheral biofeedback, where we would be correcting peripheral blood flow in addition to correcting brain activity. That's what I mean by neurotherapy is not a standalone discipline.
So that's where you put the electrodes on the wrists and whatnot?
Correct.
Okay.
Yeah.
Now, Moira, just before Dr. Swingle continues, when you characterize a panic attack, are you talking about the sudden, all of a sudden your heart starts racing out of control and you think that you're going to faint type thing, or?
Well, it's not me, but yeah, the person usually feels like they're having a heart attack, and
yes,
that's what they say. They feel like they're having a heart attack.
I actually had one of those a couple of years ago. It scared the hell out of me.
Well, you had a predisposition to it, if you remember. Right. You had a deficiency in the back of the brain, which is poor stress tolerance, which is what we usually find with panic disorder, is an inefficiency in the occipital region in the brain, the back of the brain, in which it's inefficient in self-quieting. So that what we would do is correct that in panic disorder. Now, one of the major physiological reactions in panic disorder is what's called premature ventricular contraction in the heart. That's the biggie, because you feel a sickish feeling up in the top part of your chest. You feel you can't get to the top of your breath. You feel like you're coming apart at the seams. There's no reason for it. You don't quite know why that's happening. You feel you're having a heart attack. You don't know what's happening. You feel you're going to faint on the spot. So in addition to correcting the brain activity, we want to correct the peripheral blood flow usually. And we want to have a look at whether there's any premature ventricular contraction, because there's a biofeedback method for correcting that as well.
It was very scary, and I actually got sent to the hospital because the doctor didn't know why the heart was racing so badly out of control.
Premature ventricular contraction, that's exactly what that was.
And then it was shortly after that you and I met. Our topic has been depression and mood disorders with Dr. Paul Swingle, who is a registered neurotherapist, psychologist. Back to the phones we go at 280-CFUN. Tammy, you're on with Dr. Paul Swingle. Thanks for being with us.
Hi there. Dr. Swingle, I have been suffering from chronic fatigue syndrome.
Yes.
But I'm having a lot of trouble getting medical evidence and all that kind of thing that people, my doctor and other specialists are not, it's all subjective. So I'm just wondering, is that something you can treat?
We treat a lot of chronic fatigue syndrome. A lot of the symptoms and a lot of the neurological indicators are very similar to fibromyalgia, in which, generally speaking, there's an excess amount of slow frequency in the prefrontal cortex. Did you have an accident before you developed chronic fatigue?
I've been in a couple of car accidents, about a 4-year window in between, and I think I had some chronic fatigue after the first one, and it sort of escalated more after the second one.
Yes, that's quite typical. Yeah, I think we've got the frontal damage that we can correct that's associated with the chronic fatigue.
That chronic fatigue syndrome, that seems to be something that came around 10 to 15 years ago. At least it was labeled that way. And Tammy brings up a great point, is a lot of people have a tough time supporting the medical evidence for that.
Yes, the title, It's All in Your Head, is perfect here.
Yeah.
Because people who come in with chronic fatigue, and the physician would say it's all in your head, basically, or you're depressed. That was the other thing. Chronic fatigue can be related to depression, but the depression tends to be reactive. The person's fatigued, they can't do what they want to do. Of course they get depressed. So we treat the chronic fatigue aspect of it. Unless they have a predisposition to depressed mood states, then we would correct that as well.
Tammy, thanks for the phone call. Off the top, you mentioned postpartum depression. We haven't mentioned that throughout the program. What exactly is it? And I know it can be really, really bad for some women. And can you treat it?
Yes, we see a lot of folks with postpartum depression. About 10 to 20% of women develop postpartum depression. There's a higher rate the younger the mother. Adolescent mothers have a higher probability of postpartum depression. There are a lot of risk factors involved. History of depression, of course, in the family. Depression during the woman's pregnancy. If she has a history of premenstrual mood disorders. We talked earlier about poor social support. If the woman has poor social support or a poor partner relationship, then, of course, the risk factor goes up. Stressful life events, social isolation, and so forth. All of those are risk factors associated with developing postpartum depression. Neurologically, what we tend to find with women who come in with postpartum depression is the poor stress tolerance issue, in which the back of the brain is inefficient in terms of stress tolerance. So she's overwhelmed by what happens with trying to care for a new infant. And secondarily, the frontal lobes usually indicate a predisposition to depressed mood states. So if we correct that, we can make a big difference.
And that leads to a lot of terrible things, though, especially with younger mothers.
Horrible. Yeah.
Well, we've covered a lot of ground here today, and I know that you have a lot of clients and patients who do come in because of depression, but I guess just getting back to the very first thing that we talked about today in depression, and if you or someone you know suffers from either debilitating or mild depression, the key for you is to identify what kind of depression it really is before there's any treatment or medication involved.
That's right. We want to do a brain assessment to see what we're dealing with. There are many forms of depression, some of which are quite normal. You would expect to be depressed if a loved one dies, for example, or you lose a job. There are times of year when you become more depressed. Now, if you become more depressed than other folks do during that period of time, you usually have a predisposition to depressed mood states, so we can help in that regard. But we would never, ever sedate a reactive depression. Long-term depressions that are genetically based, that's a predisposition to depressed mood states. We correct that with neurotherapy. At least 50% of the people with depression have a comorbid anxiety condition, and that's the deficiency in the back of the brain. And that is also one of the things that we would treat. So we would treat those two areas in the brain.
Next time you're here in a month or so, fibromyalgia and chronic fatigue, and we had Moira there talking about, or Tammy, I believe it was, who was talking about chronic fatigue. What can we expect to talk about in a month's time?
Fibromyalgia, there are three general causes of fibromyalgia: brain injury, emotional trauma, and viral infection. It's integrally related to depressed mood states, of course, and a lot of physicians treat it as though it were depression as opposed to some other condition. Usually we find both men and women who have fibromyalgia usually have a severe sleep problem, comorbid other conditions, and depression. That's usually what we find.
All right, so we'll have that in a month. Today's show can be found on Dr. Swingle's website at swingleandassociates.com. Just check under the media section. It's easy to navigate around. Again, Dr. Swingle's clinic number is 604-608-0444. That's 608-0444. And the clinic is downtown on Melville Street. Thank you as always. It's always fascinating chatting with you. We'll talk to you in a month. It's Dr. Paul Swingle, and this is It's All in Your Head.